All right, for part two, we're going to be looking at the appendix. So if you do like this kind of content, please leave a like and comment. It's going to take a long time to do. If you're looking for a certain part in this video, please look at the description. I'm going to timestamp everything, even though it takes a lot of time. But with that being said, we need to get straight on to it. All right, so starting off with the automatic external defibrillator. So the introduction, the AED should be applied only to patients who are unresponsive and have no signs of circulation. The indications are a sudden unresponsive, presumed to be of cardiac origin, a patient is pulseless and unconscious, and the patient is greater than or equal to 1 month old. So you want all of these things here. The contraindications is a patient who are documented to be a do not resuscitate or DNR, a patient who has a pulse or is still conscious, patient less than 1 month old, a patient with obvious signs of death such as rigor mortis or dependent lividity. So the procedure, you want to establish a patient's responsiveness. You want to check their airway and open it as needed. Determine if the patient is breathing. Use a BVM or bag valve mask as needed. Check for a pulse. If a pulse is absent, begin CPR. Make sure that the patient is supine and on a dry surface if possible. Expose the patient's chest. Attach an AED cable to the appropriate size AED, either adult or pediatric. Do not apply to a patient lying in the water. Make sure that the unit is turned on and that there's no portable cellular phones or radios within 6 feet of the patient. I didn't know that. Oh my gosh. Remove the self-adhesiveness defibrillator pads from the packaging. Peel off the protective backing and apply to the patient's chest in the proper locations in accordance with the illustration on the AED pad packaging. Make sure that the chest is dry and that any medication patches, such as nitroglycerin, are removed. Do not apply the pads directly over a pacemaker or an AICD. Stop CPR and do not touch the patient. Allow the AED to assess the rhythm. Voice and or visual prompts may be given depending on the unit. The Assess or Analyze button on some AED models may need to be pressed. It is very important not to touch the patient or disturb them during the analysis phase. Doing so may potentially result in misinterpretation of the cardiac rhythms. There are 3 possible messages after pressing Analyze. If the AED decides that a shockable rhythm is present, it will state start CPR and allow for 2 minutes of chest compressions. During this time, the AED is silently charging for defibrillation. After 30 seconds, the AED will say shock advised, stand clear, push to shock. Immediately clear from the patient and depress the shock button. Chest compression shall resume immediately after the defibrillation without a pulse check. Without a pulse check. So start chest compressions immediately, don't do a pulse check. If the AED detects a non-shockable rhythm, it will state no shock advised and start CPR. Not all patients in cardiac arrest will have a rhythm that should be shocked. After 2 minutes, the defibrillator will say push analyze. The AED may also say motion detected, stop motion. The AED is unable to analyze due to motion. Make sure no one is touching the patient, wires, or device. The device will automatically analyze when the motion stops. Recheck the patient's airway, breathing, and for a pulse. If needed, resume CPR. If the patient loses a pulse at any time, EMS witnessed arrest, immediately press Analyze. After every 2 minutes, stop CPR, do not touch the patient, and allow the AED to reassess the rhythm. The Analyze or Assess button may need to be pressed on some models. Continue these above steps until the MICU or the MICU ambulance arrives if applicable. Report to the MICU crew the time and number of shocks that were delivered. If a patient has return of spontaneous circulation, refer to the post-ROSC management protocol in page 83 or in the last video. Note, patients with automatic implanted internal cardiac defibrillators as an AICD should be treated just as other patients. No special considerations are needed in the pre-hospital setting except avoiding placement of the pads directly over the AICD or pacemaker. There is no limit to the maximum number of shocks delivered as long as the AED is advising for shock to be administered. For airway management or oxygen administration, to introduce this, oxygen therapy remains one of the most important interventions a pre-hospital provider can do. The early administration of oxygen is very important and is stressed throughout these protocols. Any patient with an altered mental status, significant shortness of breath, significant ventricular ectopy, cyanosis, or evidence of hypoxia or ischemia needs to be on high flow 2 via a non-rebreather mask. Patients without active shortness of breath or altered mental status that need oxygen can be placed on oxygen via a nasal cannula at 2 liters per minute or 28% oxygen delivered. Of 4 liters per minute, 36% oxygen delivered based on the paramedic's judgment. Oxygen at a rate of greater than 4 liters per minute is very irritating to the nasal mucosa and should be avoided. Often agitation and restlessness are the results of hypoxia. Consider intubation for all patients with an altered mental status and a decreased gag reflex. Never withhold oxygen from a patient who needs it. In COPD or emphysema, patients with a hypoxic drive with oxygen still indicated. Watch closely for respiration depression and assist ventilations with a BVM as needed. Always use an end-tidal CO2 detector, an EasyCap, to verify endotracheal tube placement. It should be turning from purple to yellow or gold if it's in the trachea. Gold is golden. In addition, continuous CO2 capnography should be monitored on all intubated patients. See the ETCO2 Monitoring appendix on page 146. Do not let a normal pulse oximetry reading give you a false sense of security that the patient is ventilating okay. Often, a patient will have a relatively good PO2, a normal oxygen saturation, while the PCO2 is increasing dangerously high. Always treat the patient, not a pulse oximeter reading. See the pulse oximetry appendix on page 177. Administer oxygen to keep the patient or to keep the pulse oximetry reading greater than 94%. In COPD patients, an O2 saturation greater than 94% may not be achieved. For the progression of airway management, a nasal cannula should go from 2 to 4 liters per minute. From there, you should consider a non-rebreather mask with high flow oxygen at 10 to 15 liters per minute. CPAP is next, a BVM, and then an endotracheal intubation. For an endotracheal intubation, indications for intubation is to protect the patient's airway if the patient is presenting with a decreased or absent gag reflex, a GCS or a Glasgow coma score less than 8, oxygenate, provide oxygen, or ventilate, remove carbon dioxide, airway control in a burn patient, medication administration for a cardiac arrest patient. Remember to administer Narcan or naloxone prior to intubating a patient with suspected opioid overdose. Intubation may not be needed after the naloxone is administered. Administer midazolam versed 1 to 5 milligrams slow IV or IO push, or 2 to 5 milligrams intramuscularly or a mucosal atomizer device, which just means intranasal, may be needed for sedation in a head-injured patient who has significant jaw clenching. Given the time constraints involved, midazolam may be administered by the medic before contacting medical control if needed to aid with the intubation attempt. For intubation equipment, have all the equipment out and available before attempting intubation. Have a BVM with oxygen, ETCO2, a laryngoscope with the appropriate blades. Due to the infant's floppy epiglottis, a straight Miller blade should be preferred over a curved Macintosh blade in infants. A 10 milliliter syringe, an endotracheal tube stylet, a bougie tracheal tube introducer, suction, a stethoscope, appropriately sized endotracheal tubes. Often it is a good idea to have out the tube size above and below the tube used in case an adjustment is needed. The approximate endotracheal tube size in a child is the size of a child's external nair or the size of the child's little finger. Alternatively, the pediatric endotracheal tube size is age divided by 4 plus 4. Use an uncuffed tube in a patient less than 8 years old, and cricoid cartilage is the narrowest portion of the child's airway. Twill tube, the umbilical tape, tie downs, or pink tape, or commercially used tube tamer type devices are useful. Magel forceps to remove foreign bodies if encountered. An eye gel for rescue airway devices if needed. For the intubation procedure, prepare and oxygenate your patient with 100% O2. Select the appropriate ET tube size and insert the style into the tube. Have suction ready if needed. An NPA or an OPA should be placed on any patient who is receiving BVM ventilations. Avoid an NPA for suspected nasal, midface, or basilar skull fractures. All patients that are intubated should be on a cardiac monitor and pulse oximetry if the time allows. Hypoxia will rapidly lead to bradycardia in a child. Lidocaine, 1.5 mg per kilogram IV, may be administered 1 minute prior to intubating a closed head injury patient with suspected increased intracranial pressure. Remove any dentures present before intubating a patient. If unable to pass the endotracheal tube after 30 seconds, stop the attempt, pre-oxygenate with a BVM, and reattempt with any adjustments as needed. You can change their head's position, change cricoid pressure, use a burp maneuver, a different medic, different size tube or blade, etc. The bougie tracheal tube introducer can also be used in aid for placement. Once the tube is correctly placed, inflate the ETT cuff up to 10 milliliters of air and check for equal breath sounds in all 4 lung quadrants and absent over the epigastrum. If the breath sounds are unequal, adjust the endotracheal tube position as it may be too deep, i.e. a right mainstream bronchus intubation. Confirm the endotracheal tube placement with an ETCO2 detector, or better, perform continuous CO2 capnography on all intubated patients. Document the end-tidal CO2 results on the patient care report. ETCO2 capnography should be greater than 20 units. If the patient has a pulse, in a pulseless patient, an ETCO2 waveform with an end-tidal CO2 value greater than 10 may be used to confirm the adequacy of an airway. In adults, placing the tube to a depth of 21 centimeters in a female and 23 centimeters in a male will have the tube in the correct location 90% of the time for all patients. Secure the tube carefully in a child. A child's trachea is short in length, and only a small amount of movement can lead to incorrect movement of the tube. A C-collar can be placed in a child to better maintain the ET tube placement. Always disconnect the BVM from the endotracheal tube whenever moving the patient onto a backboard or a stretcher into the back of the ambulance, etc. to avoid dislodging the tube. Always reassess the breath sounds immediately after moving the patient and frequently during transport. Continuous ETCO2 or capnography monitoring should be the standard of care on all patients with respiratory failure and or advanced airway placement. Never feel obligated to have a patient intubated. A BVM with a good seal and nasal trumpet or an OPA usually does an excellent job of oxygenating and ventilating a patient. Always pull an endotracheal tube immediately if any doubt exists whether the tube is placed correctly in the trachea. When in doubt, take it out. Never place an endotracheal tube unless it can be seen passing through the vocal cords. Unrecognized esophageal intubations will not be tolerated. Administer midazolam or Versed 1 to 5 milligrams slow IV push or IO, IM, or a mucosal atomizer device. Or morphine sulfate 2 to 10 milligrams, 0.1 milligram per kilogram for a child, slow IV push, or IO, which means intraosseous in the bone, or IM. Or fentanyl 50 to 100 micrograms for tube tolerance if needed, a patient biting down on the endotracheal tube. For iGel protocols, the iGel is for adult and pediatric patients and is meant to be a rescue airway device for patients that cannot be successfully endotracheally tubed, or as the initial airway device for a patient in cardiac arrest. There is no need to later place an ET tube. EMS personnel that use the iGel must demonstrate proficiency in use prior to having authorization to use it. The end-tidal CO2 detector should be used to help confirm ventilation of the proper tube. The iGel cannot be used as medication administration route. No medications are to be administered down the iGel airway. The iGel, by its design, does not require a mask seal, and thus may be very useful in situations in which an adequate BVM face mask seal cannot be maintained. The iGel will be carried in 6 sizes. It will either be blue, gray, white, yellow, green, or orange. If you want, you can pause the video and you can look at the weights here. The iGel is indicated in the following patients: for apneic patients when endotracheal intubation is not possible or available, initial airway devices in a cardiac arrest patient, a patient is unconscious without a gag reflex. It's contraindicated for the following patients: they're under 5 kilograms, with an intact gag reflex, a history of recent caustic ingestion, known esophageal trauma, or known esophageal disease, obstructive lesions below the glottis, patients with a tracheostomy or a laryngectomy. I'm not sure how to say that. iGel device warnings and precautions. The iGel is considered a supraglottic airway. The iGel is not a definitive airway. It does not completely protect the airway from the effects of regurgitation and aspiration. After placement, perform standard checks for breath sounds and utilize an appropriate carbon dioxide monitor as required by protocol. The iGel is not intended for reuse. Here's a little diagram of how you can use the iGel. I will not be going over it. You can YouTube that. The iGel device procedure. Attach a pulse oximetry device to monitor oxygen levels if the patient is still breathing. Choose the correct size iGel based on the patient's weight. Suction patient prior to insertion of the eye gel if indicated. Apply a small amount of lubricating gel to the back side and the front side or the front of the eye gel to aid in insertion, but do not over lubricate. Hold the eye gel at the integrated bite block with your dominant hand. With your non-dominant hand, open the patient's mouth and apply a chin lift unless contraindicated by C-spine precautions. The patient should be in the sniffing position with the head extended and the neck slightly flexed forward. If a cervical injury is suspected, use a modified jaw thrust instead of any flexion at the neck. The chin should be greatly pressed down inferior before proceeding to insert the eye gel. Position the device so the eye gel cutoff outlet faces the patient's chin. Advance tip into the mouth of the patient in a direction towards the midline of the hard palate. Without exerting excessive force, continually advance the device downwards and backwards along the hand palate until a definitive resistance is felt. If there is excessive resistance felt during the eye gel insertion, a jaw thrust and slight rotation of the device is recommended. At this point, the tip of the eye gel should be located into the upper esophageal opening, and the cuff should be located against the laryngeal framework. The incision should be resting on the integral bite block. Attach the BVM to the 15 mm connector of the eye gel and begin bag valve mask ventilations with 100% oxygen. Confirm proper placement by auscultating of breath sounds, chest rise, oxygenation saturation, and verification of the ETCO2 when available. Secure the eye gel to the patient using tape or with included manufacturer's securing device. Reassess the position of the eye gel device after each and any significant movement of the patient. Continue to monitor and sedate the patient per protocol as necessary. For the APGAR score, it's based on a scale of 0 to 10. So you have appearance, which is color. There's pulse, grimace, which is caused by irritability on suctioning, activity, which is their muscular tone, and their respiratory effort. You can go from 0 to 2. We're not going to go over it, but if you need to, you can always YouTube it, learn more about it. Some notes: the APGAR score is measured at the time of birth and repeated at 5 minutes after birth. It is unusual for an infant to have an APGAR score of 10, even at 5 minutes, because the infant is usually not totally pink. You will have some residual cyanosis of the fingers and toes. Be ready for that and just kind of accept it. For cardiac monitoring, a 4-lead and 12-lead acquisition and transmission. Any patient who receives ALS interventions, either by medications, an advanced airway, IV, or etc., must be on the cardiac monitor. All patients with an altered mental status, chest pain, shortness of breath, abdominal pain, syncope, dizziness, tachycardia, hypotension, vomiting, or seizures must be on the cardiac monitor. For a 4-lead, you can apply the 3 EKG electrode patches in the standard fashion on a clean, dry skin. I'm not going to say all this. You just need to know how to do a 4-lead, buddy. You need to know how to do a 12-lead, okay? But a 12-lead cardiac monitoring. If the ambulance has 12-lead capabilities, we do. A 12-lead EKG should be obtained on adult patients presenting with suspected myocardial or cardiac chest pain, cardiac dysrhythmias, including bradycardia, tachycardia, on a monitor, altered mental status, suspected CHF or congestive heart failure, or possible tricyclic antidepressant drug overdoses. 12-lead EKGs are not considered vital interventions and should be obtained at a paramedic discretion depending on the patient and if time allows. The paramedic must feel that a 12-lead EKG would not interfere with life-saving care. 12-lead EKGs should never significantly delay transport to the hospital and should not be done on unstable patients that are hypotensive with VTAC or VFib with a 3rd-degree AV heart block. They should not be obtained in a public place unless the patient's privacy and dignity can be maintained. Procedures for obtaining a 12-lead? You gotta know how to do a 12-lead. I'm not saying all that. Obtain the 12-lead and print out a paper copy. If the ambulance is equipped, transmit any abnormal 12 leads to the receiving hospital. Notify the receiving hospital that a 12-lead EKG was or will be sent so the physician can review the 12-lead EKG prior to arrival. This is huge. If the patient is having an inferior or posterior acute myocardial infarction, perform a right-sided 15-lead EKG to evaluate for a right ventricular infarct. Move V4 to V4R. Nope. Just know how to place it. You're going to have to YouTube it, sorry. Due to artifact from excessive vibration and electrical interference on the ambulance, ideally the 12-lead EKG should be performed only when the motor has been turned off during the 12-lead acquisition. It is realized that this might not be possible in certain situations, i.e. extreme hot and cold days, when the ambulance must be continuously running. Acquiring the 12-lead EKG should not normally prolong scene times more than an extra 2 minutes. For CPR, the parameters by age for a neonate, if they're less than 1 hour of age, you want their ventilation rate to be between 40 to 60 per minute. For a 2 rescuer CPR ratio, you want it to be 3 to 1. And for chest compression rates, you want it to be 120 per minute. For an infant, if they're greater than 1 hour or equal to, and they're less than 1 year old, you want their ventilation rate to be 12 to 20 per minute. The rest, I'm just not going to mention it for now. If it's a neonatal patient, if it's less than 1 year or 1 hour of age, then we want to do a 3 to 1 2 rescuer CPR ratio. We want to wrap our hands around, use our thumbs or some variant of that. If it's an infant, so greater than or equal to 1 hour to less than 8 years old, we want to do 15 to 2. 8 years old and greater, we want to do a 30-2 ratio, but I mean, this is just telling you how to do CPR. You can read it at with your own choice, but I'm not going to read all that. For a Cincinnati pre-hospital stroke scale, have your patient smile. Have your patient hold arms out with palms up for 10 seconds with the patient's eyes closed. Have the patient speak a sentence. You want to look for facial droop. You want to make sure that both sides are equal. You want to look for arm drift. You want to make sure that both arms are equal. And you want to look for speech and make sure they use the correct words with no slurring. You don't want to see any abnormal speech or if they're mute. For CPAP, or continuous positive airway pressure, the indications for CPAP are, for CPAP ventilations, is indicated for treatment of impending ventilatory failure in an attempt to avoid endotracheal intubation and invasive ventilation. This non-invasive positive pressure ventilation, or NIPPV, support system is best applied to patients whose respiratory failure is expected to respond quickly to medical therapy. The patients must meet all of the following criteria. They must have dyspnea with pulmonary edema, CHF, such as rales, crackles, or wheezing auscultated. They may include COPD patients in moderate to severe COPD exacerbation. An awake patient who is able to follow commands. A patient must be able to protect their own airway, a gag reflex must be present and handle secretions. Respiratory distress with resistant hypoxia. For example, the asthma patient has not responded to albuterol nebulizer and oxygen administration. The contraindications are a decreased level of consciousness or being unconscious, respiratory arrest or agonal respirations. A patient is unable to maintain and protect their own airway. They have an uncontrolled or persistent vomiting. Suspected pneumothorax or penetrating chest trauma, hypotension less than 90 units, impediment to proper mask placement, fitting, e.g. a recent facial surgery or epistasis, a pediatric patient who's less than 10 years old who is too small for the CPAP mask to fit properly, a tracheostomy, weak respiratory efforts. The patient must be able to overcome the CPAP pressure during expiration. The equipment is a CPAP machine with head straps, tubing, and a pressure relief valve, an oxygen cylinder with a 25 liter per minute regulator, and a T-piece if albuterol nebulizer needs to be administered. You can administer both at the same time. The procedure, I put it on them. I'm not going to say it. No. For notes, CPAP is considered an advanced life support skill and is only to be used and monitored by paramedic personnel. CPAP has been shown to improve the gas exchange, to improve the work of breathing, decrease the sense of dyspnea, and the need for endotracheal intubation in patients who suffer shortness of breath from asthma, COPD, pulmonary edema, CHF, and pneumonia. CPAP raises the inspiratory pressure above the atmospheric pressure and then applies PEEP, or positive end expiratory pressure, during exhalation. CPAP is a method of patient ventilation which provides a non-invasive continuous positive pressure ventilation to prevent alveolar collapse. The goal is to decrease the work of breathing, enhance oxygenation, and improve carbon dioxide ventilation. Most patients will improve within 5 to 10 minutes, increase oxygen saturation with less work of breathing. If there is no improvement within this time, consider the assisted ventilation with the BVM if indicated. Make sure that the receiving emergency department is aware in the radio report that CPAP is being used in order for the ED to prepare the necessary equipment and personnel for the patient. Upon hospital arrival, do not remove the CPAP until the emergency department is ready to transfer the patient over. Consider the use of nitroglycerin 0.4 milligrams sublingually or spray for hypertensive patients with suspected congestive heart failure or pulmonary edema prior to initiating CPAP. Do not give nitroglycerin to significantly wheezing patients. CPAP does not violate DNR or do not intubate orders. The CPAP flow pressure ratings are 15 liters per minute is at 5 PEEP, 20 liters per minute is at 7.5 PEEP, and 25 liters per minute is at 10 PEEP. For a crime scene, it is very common for EMS personnel to respond to a scene where there is a possibility that a crime has been committed. Possible crime scenes may include victims of assault and battery and sexual assault, as well as suspects under arrest and injured police officers. Even a motor vehicle collision can be a crime scene and may potentially involve the investigation of charges such as driving while intoxicated, possessions of narcotics, vehicular manslaughter, reckless driving, and a variety of other crimes. In dealing with a possible crime scene, it is important to protect yourself, preserve important evidence, and still carry out the function of providing emergency care. When pre-hospital personnel encounter a dead person, or if they enter a scene where foul play is suspected or being considered, the following guidelines should be strictly adhered to. First off, establish scene safety. Make sure law enforcement is en route, if not already present. Do not enter an unsafe scene until it is safely secured by law enforcement. If you unknowingly arrive at a scene and suspect the possibility that a crime has been committed, have dispatch send out law enforcement. Be careful not to touch or alter any surroundings unless it is absolutely necessary. This includes telephones, doorknobs, and other articles that may contain fingerprints. Do not leave any personal items such as gum, wrappers, cigarette butts, medical supplies, or packages, etc. at the scene. If anything at the scene, including the patient, is moved, law enforcement must be advised. Never touch anything that has been used as a weapon. Limit access of the immediate scene to essential personnel only. The fewer the people who walk through the crime scene, the lesser the chance of disturbing evidence. Entry and exit routes should remain the same, one path of travel. When establishing if a patient is still alive, especially at a suspected homicide scene, it is often best if only one crew member enters the immediate patient area initially. Avoid walking through blood if present. Any suicide note should not be handled. If a viable patient is encountered, proceed with patient care. The following situations and responses may be indicated. If there is a hanging, leave all knots intact, including the knot that the rope is suspended from and the knot making the noose. If the rope has to be cut for patient care, cut the rope in an area halfway between the noose and the suspension point. For weapons, unless absolutely necessary, EMS personnel should not move any weapons if possible. This should be left to law enforcement. The weapon should be removed to a safe place far away from the patient and bystanders. Firearms should not be tampered with, opened, or unloaded. When treating patients that have sustained penetrating wounds and the clothes need to be removed, do not cut through knife or bullet holes. It may affect subsequent evidence analysis. For sexual assault, it is important that the victims of sexual assault be moved quickly to a safe environment. It is vital that the patient not shower or wash any part of their body or clothing, change their clothing, or use the bathroom. If the patient's clothing or underwear have already been removed, then either bring them into the emergency department with the patient for evidence collection or leave them with law enforcement. All sexual assault victims should be transported to Doctors Regional Center Adults and Driscoll's Children's Hospital for Children unless immediate trauma care is needed at Christus Spawn Shoreline. Never use verbiage such as sexual assault or RPE on any radio communications. Protect patient privacy. That's huge. The term assault can be used by itself, or if necessary, the emergency department may be contacted via a cellular phone. Bodies of patients determined to be dead at the scene are not to be moved until authorized to do so by the justice of the peace or a medical examiner. This may require, in some instances, that the ambulance remains on the scene until the release by the justice of the peace. All invasive interventions on a crime victim should be noted in the emergency run report, and if needed, by marking the victim's skin with the letters EMS at the sites of invasive interventions, where you might have tried to establish an IV. Occasionally, crime scenes are such that law enforcement may declare a patient dead and prohibit EMS personnel from entering the scene. When the situation arises, the senior paramedic should discuss the situation thoroughly with the officers in charge. Note: Whenever it is necessary to remove any item from a crime scene, it is important that every effort must be made to comply with the chain of custody or the chain of evidence procedures. The evidence must always be in the possession or custody of an identifiable person or secure, locked place. A dying declaration. It's a statement made by severely injured patients prior to death which either indicates the name of the person responsible or provides other facts relevant to the commission of the crime. Such statements may be admissible in court if the victim is critically injured, has a sense of impending death, and does not believe that there is any hope of recovery. In the event that you are present for such a statement, it is important that you try to remember the victim's exact words and the circumstances surrounding the statement. Try to record the information in writing and pass it on to law enforcement as soon as possible. For EMS Patient Care Report, the EMS Run Report is a medical record and is thus subject to confidentiality. You should not release the EMS Patient Care Report to law enforcement unless presented with a valid subpoena. Do not do that. When dealing with a conflict with a law enforcement officer in the field, always remember that the EMS person's primary objective is to the patient as a provider of emergency medical care. Always document your observations carefully on the patient care report. For determination of death in the field or termination of resuscitation, there are certain situations in which life support measures may be withheld or terminated in the pre-hospital setting. The following protocol describes these situations. The first is there is a written, valid Texas DSHS or out-of-hospital DNR or Do Not Resuscitate order, advanced care directives or nursing home orders signed by the patient's physician. A valid DNR form has been signed by the patient or next of kin or a legal guardian, notarized and dated. The EMS crew must be confident in the authenticity of the DNR paperwork and in confirming the patient's identification. Ideally, the original DNR form should be transported to the hospital with the patient. However, it is realized that there are instances when a copy of the DNR form is presented to the EMS personnel. As of September 1999, or 1999, a copy of the valid state DNR is acceptable. Medical control should be contacted for guidance as needed. Number 2, the patient has sustained injuries that are obviously incompatible with life, including burn beyond recognition, such as incineration, decapitation, blunt trauma with absent vital signs, no pulse or respirations, and no signs of life, mortal gross evisceration, and a crushed head with protruding brain matter. Some obvious signs of death are present, including dependent post-mortem lividity, venous pooling of the blood in gravity-dependent areas occurring 1 to 2 hours after death and peak at 6 hours, rigor mortis, which is a stiffness which occurs 2 hours after death and peak at 5 to 12 hours after death, gross decomposition. When life support measures have already been initiated by the first responders or other medical personnel, resuscitation may only be terminated by medical control, unless any of the above criteria are present. When contacting medical control, begin the radio report by stating, "This is a request to discontinue CPR." If a patient has not responded to confirmed intubation or IG airway, IV fluids, 2 rounds of ACLS medication, and remains pulseless in assistedly or PEA less than 20, with medical control, you may contact them for pronouncement in the field. Medical control must be contacted for an order to discontinue resuscitation. Note: remember that the paramedics are not legally able to declare a person dead. Only physicians, a coroner, or the justice of the peace can legally declare a person dead in Texas. The pre-hospital personnel do not pronounce death, but rather determine death. Make sure that the medical examiner's office is notified. The paramedic should stay with the body until law enforcement allows them to clear the scene. It is not necessary in all situations to wait for the justice of the peace. Patients with the potential or suspected hypothermia should not be pronounced in the field. Occasionally, it may be necessary to transport a child with obvious death due to parental expectations of EMS personnel. Use good judgment depending on the scene situation or environment and medical control for guidance as needed. If any doubt exists, always err on the side of continuing resuscitation and transporting the patient to the hospital. Patients in VFib or VTAC should never be pronounced in the field. Penetrating chest and abdominal traumatic arrest have a small chance of survival. If vital signs were present in the field, these patients should be transported to the hospital. If the resuscitation is terminated in the field, tie off and knot any established IV lines. All IVs and IO catheters, and the endotracheal tube or I-gel will remain in place. The family and relevant bystanders should be approached and notified that all resuscitative efforts have failed to restore a pulse and that transport of the patient to the hospital is not going to change the patient's ultimate outcome. At all times, EMS personnel need to be very attentive to the social and psychological support needs of the survivors, i.e., family, friends, and witnesses. Mass casualty incidents, MCIs, may require exceptions to this appendix. Do not resuscitate, or DNR. Based on the Texas DSHS out-of-hospital do not resuscitate orders, healthcare professionals, either physicians, nurses, EMS personnel, must honor out-of-hospital DNR orders in accordance with the statewide DNR protocol. The purpose of the DNR is to allow patients to direct healthcare professionals in the out-of-hospital setting to withhold or withdraw specific life-sustaining treatments such as CPR, defibrillation, ACLS medications, intubation, artificial ventilation, and transthoracic external cardiac pacing in the event of respiratory or cardiac arrest. An out-of-hospital DNR applies after the cessation of spontaneous respirations or circulation. The DNR is used in addition to living wills and durable power of attorney for health care documents. The DNR does not include authorization to withhold medical interventions or therapies considered necessary to provide comforting care, including water or nutrition, or to alleviate pain. There are no time-related criteria, e.g. 6-month life expectancy, for the DNR form. An out-of-hospital DNR order is effective until it is revoked. Since September 1st, 1999, a physician is no longer required to certify that any individual has a terminal condition. The Texas State Bill 1260 out-of-hospital DNR orders do not apply to known pregnant persons. The DNR form. The DNR form must have a title that readily identifies the document as an out-of-hospital DNR order. Either the original DNR form or a photocopy should travel with the patient during inter-facility transfers. It is realized that some nursing homes may be reluctant to release the original for fear of being misplaced in the emergency department, etc. A copy of the original DNR will suffice, and this was placed into law by the state of Texas in September 1999. Some definitions to note. An advance directive is a document or order which is prepared at request of the patient, an authorized family member, or other legal representatives, in some cases, a physician, to ensure that certain treatment choices are followed at a time when the patient is unconscious, comatose, or otherwise unable to make medical decisions. A living will is a document which states that types of life-sustaining medical treatment that a patient wants or does not want in the event of terminal illness, coma, or persistent vegetative state. A healthcare power of attorney or a durable power of attorney allows a person to appoint or designate a specific individual to make healthcare decisions when the patient is incapable of doing so. Patient identification. EMS providers identify patients as having a DNR order when the Texas DSHS out-of-hospital DNR form is present and appears valid. Signatures are present in the required areas. The patient is wearing an approved ID device. They must verify that the ID device is in fact the patient with witness on scene if possible. Approved ID devices consist of a vinyl bracelet, metal bracelet, or a necklace. The presence of a DNR identification device on the body of a person is conclusive evidence that the person has executed or issued a valid out-of-hospital DNR order. Responding healthcare professionals shall honor the DNR identification device as if a valid DNR order form executed or issued by the person was found in the possession of the person. The patient's attending physician, either on scene or via the phone, directs the provider to withhold any resuscitative measures. Phone conversations should be documented with a callback number and should be confirmed by your partner. Patient's care documentation on the EMS patient care report must include, per Texas DSHS guidelines, the following information: detailed physical assessment of the patient, confirmation that a DNR order was present, any problems accepting the DNR order, the name of the patient's attending physician, the name, address, and phone number of a witness used for patient identification. Texas DSHS regulations regulate that a record shall be made and maintained of the circumstances of each emergency medical service response in which an out-of-hospital DNR order or DNR identification device is encountered. Interventions to be withheld include CPR, endotracheal intubation, or I-gel artificial ventilation, defibrillation, including an AED, transcutaneous cardiac pacing, and cardiac resuscitative medications. The revocation of a DNR. The DNR order may be revoked by a patient or someone with the patient's directive, a medical power of attorney. The DNR is automatically revoked in cases of a known pregnancy of a patient and suspected criminal activity involving the patient, including suspect protocol considerations per Texas DSHS recommendations, on-site conflict resolution processes. In the event of an on-scene conflict, EMS personnel should start or continue the resuscitation efforts until a verbal order is given by medical control or the patient's attending physician. Transport guidelines. EMS providers who recognize a DNR while transporting a patient should withhold or withdraw life-sustaining efforts upon discovery of the DNR order and continue transport to the receiving hospital. Out-of-state DNR orders are written out-of-state DNR orders and are to be accepted if there is no reason to question the authority and authenticity of the DNR. Reporting requirements for healthcare providers. All out-of-hospital healthcare providers are required to report specific information regarding the DNR encounter to the Texas DSHS Bureau of Emergency Management at the time of relicensure. EMS records should include all of the following: the number of DNR orders encountered by the EMS agency, including the number of DNR orders you are present and honored, as well as those presented and not honored. The number of DNR orders you are unable to comply with, provide brief detail if available. The assessment of the patient's physical conditions, whether a DNR form or identification device was used to confirm the DNR order, any problems relating to the implementation of the DNR order, the name of the patient's attending physician, the full name, address, phone number, and relationship of any witnesses used to identify the patient. Out-of-hospital do not resuscitation procedures. The following care will be initiated if a patient presents with a complete Texas DSHS out-of-hospital DNR form with verified identification. Number 1, honor the DNR order if a patient presents without a pulse, a patient presents without respirations, excluding airway obstructions, a DNR order from the patient's physician presents at the scene will be honored. Note: EMS personnel should get in the habit of inquiring about the DNR code status of all elderly patients encountered, especially at nursing homes. In any case where doubt exists about a DNR order, the paramedic should commence appropriate resuscitative measures and contact medical control for guidance. In the event of a radio communication failure, resuscitative measures shall be initiated. The state DNR form will not expire unless there is an expiration date added to the document itself. However, if an expiration date exists and the patient lacks the capacity to make informed healthcare decisions on or after the date, the DNR shall remain in effect. If the patient with capacity states that he or she wishes resuscitative measures, the DNR order shall be ignored. Rarely, a DNR order shall be found on a minor patient with a terminal condition. This can be done by the minor's patient's legal guardian or managing conservative, blah 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 blah, DSHS. A copy of the TDH standardized DNR form per rule is included on the next page. So here is an example of a DNR form. All of this should be filled out. If it's not filled out, that is bad. For electronic control weapons or tasers, to introduce this topic, EMS may be called by law enforcement after an electronic control weapon or a taser has been deployed on a subject to assess the patient and or to remove the taser dart probes from the skin. Always be aware to look closely for secondary injuries that may result from falls sustained after the taser has been deployed. Once the taser probes have been removed, the patient does not always need to be transported to the hospital if they have the capacity and they're able to refuse EMS transport. These patients can be released into police custody. All patients with an altered mental status require a full assessment and transport to the emergency department. So the procedure is: identify the location of the probes on the patient's body. If any of the probes are embedded in the following areas: the face, the eyes, the ears, the mouth, the neck, the genitals, or the spinal column, do not remove the probes and transport the patient to the emergency department. Determine from law enforcement the patient's condition before and after the taser discharge until EMS arrival. Obtain vital signs at the earliest possible opportunity, to include pulse oximetry. Do not forget the finger stick. Reasons for violent and combative behavioral patients include intoxication, psychosis, hypoxia, hypoglycemia, overdose, or a central nervous system infection. Determine from the patient any cardiac history, any ingestion of drugs or alcohol, and the date of his or her last tetanus vaccine. Make sure to document these answers in the patient care report. A medical evaluation should be obtained to ensure that this patient or the suspect can be safely taken into detention centers or a jail. For the removal of a probe by the EMS provider, ensure that the taser device is no longer applying electrical discharge prior to contacting the darts or wires. Make sure that the cartridge has been disconnected from the taser device. Use scissors or trauma shears to cut the wire about 6 to 8 inches from each dart. Wearing exam gloves, firmly grasp the dart probes between the thumb and the index finger of one hand. Use the other hand to stabilize the skin surrounding the probe site, and remove the dart with a hard, firm jerk directed perpendicular to the skin surface. Repeat the procedure for the other probe. Use extreme caution while handling the very sharp dart probe to avoid an accidental stick. Visually examine the barb tip to ensure that it is fully intact. If any part of the barb remains in the subject, transport them to the emergency department for removal. Ascertain from the law enforcement officer whether or not they will need the dart probes to log into evidence or if they can be disposed of in a sharps container. Clean each dart probe with antiseptic solution or an alcohol prep pad. Cover each area with a sterile dressing. Inform the patient of basic wound cares and the need to seek additional medical care in the event of an infection. Make sure to document the anatomic location of the dart probe's embedment and the physical findings after dart removal in the patient care report. If the patient is combative, they may require chemical restraints. Please refer to Patient Restraint Protocol on page 169. Note: if the patient's tetanus status is unknown or greater than 10 years, ensure that the patient receives a tetanus booster within 72 hours. Due to the increased potential for litigation on a tased subject, make sure that the medical documentation on the patient care report is complete. This includes that patients are not being transported to the hospital if it pertains to this case. For end-tidal carbon dioxide or CO2 monitoring, to introduce this, physical examination alone is often inadequate to determine the correct endotracheal tube location. Fogging of the endotracheal tube does not ensure that it is in the trachea. Fogging or condensation of the tube may occur up to 83% of cases in which the endotracheal tube is inadvertently placed in the esophagus. Devices that measure the concentration of exhaled carbon dioxide are useful in confirming correct endotracheal tube placement. The end-tidal CO2 detector is an important adjunct in verifying proper ETT placement, along with the direct visualization of the tube passing through the vocal cords, bilateral breath sounds, absent epigastric sounds, and a good pulse oximetry reading. The most common end-tidal CO2 detector device on the market is the EasyCap PediCap for children that's less than 15 kilograms. In respiratory arrest patients, adjust the BVM ventilatory rate to keep the ETCO2 between 35 to 45 units. The EasyCap description. The EasyCap ETCO2 detector is a disposable colorimetric device used to detect the presence of carbon dioxide in the exhaled air of an intubated patient. The device attaches to the end of the endotracheal tube and uses a chemical-treated indicator to change color if the presence of CO2 is detected. The EasyCap is the standard of care in the emergency department after a patient is intubated and has been recently showing in legal rulings to be expected in the pre-hospital arena as well. The purpose is to rapidly and easily identify and verify the endotracheal tube placement in adults, while the PediCap is used in children less than 15 kilograms. The device has been studied well in the literature showing pre-hospital benefits, especially in COPD patients in whom breath sounds are diminished and often are transmitted to the epigastrum. The procedure for the ETCO2. Nope, you just need to know how to use it, buddy. Nope, it's gold if it works. Note: in about 10 to 30% of adult patients who are in cardiac arrest, the ETCO2 detector will not exhibit good color changes despite a correct ETT placement into the trachea. This is due to poor pulmonary blood flow that occurs during chest compressions. The poor cardiac output causes suboptimal CO2 to O2 exchange in the lungs, which reduces the amount of CO2 returned to the lungs, and not enough is present to cause a color change. The ETCO2 detector is not useful for detecting right mainstream bronchus intubation. The EasyCap will change color according to the following chart. Yep, gold is good. That's all I'm going to say. Waveform capnography, or ETCO2 monitoring. The AHA guidelines now endorse waveform capnography as a level 1 recommendation for the ET2 verification, a level 2A recommendation for detecting return of spontaneous circulation, and a 2B for monitoring CPR quality. Capnography is a non-invasive method for monitoring the level of carbon dioxide in exhaled breathing to assess a patient's ventilatory status. Waveform capnography is also an indirect measure of circulatory status and cardiac output of the patient. All patients having their airway maintained by an iGel or an ET2 should have ETCO2 monitoring to ensure successful airway control both initially and throughout the pre-hospital care of the patient. And some definitions. Hypocapnia is ETCO2 is less than 35 units. Hypercapnia at greater than 45 units. And waveforms, there's a couple different things. Bronchospasm has an alveolar plateau known as a shark fin. Very interesting things. Here are some different waveforms if you want to learn about them. I'll pause here for a moment. There you go. Loss of waveform. It maybe got dislodged or there's apnea. There's a notch waveform. There might be a pulmonary embolism or a paralytic effect. Oh, very interesting. Increased CO2, decreasing CO2. So now note. Continuous waveform capnography is recommended by the AHA in addition to clinical assessment as the most reliable method of confirming and monitoring correct placement of an ET2. Waveform capnography should be used to confirm and monitor ET2 placement in the field, in the transport vehicle, on arrival at the hospital, and after any patient transfer to reduce the risk of unrecognized tube misplacement or displacement. Studies on waveform capnography have shown 100% sensitivity and 100% specificity on identifying correct ET2 placement. The EasyCap ETCO2 device should only be used when waveform capnography is not available. It is reasonable to consider using quantitative waveform capnography in intubated patients to monitor CPR quality and optimizing chest compressions, and to detect ROSC during chest compressions or whether a rhythm change reveals an organized rhythm. If the ETCO2 abruptly increases to a normal value, 35 to 45 units, it is reasonable to consider that this is an indicator of ROSC. Capnography is a vital sign of ventilation. By tracking the carbon dioxide in a patient's exhaled breath, capnography enables paramedics to objectively evaluate a patient's ventilatory status as the medics utilize their clinical judgment to assess and treat their patients. Capnography provides an immediate picture of patient condition. Pulse oximetry is delayed. Hold your breath. Capnography will show immediate apnea, while pulse oximetry will show a high saturation for several minutes. While capnography is a direct measurement of ventilation in the lungs, it is also an indirect measurement of metabolism and circulation. For example, an increased metabolism will increase the production of carbon dioxide, increasing the ETCO2. A decrease in cardiac output will lower the delivery of the carbon dioxide to the lungs, decreasing the ETCO2. Some abnormal waveforms: if you see hyperventilation, the CO2 goes up. If you see hypoventilation, the CO2 goes down. Here's a Glasgow coma score, and you can see it goes from 3 to 15, and it lets us measure a patient's mental status, checking their eye opening, their verbal response, and their motor response. If you want to learn more, I highly recommend looking it up. For an intranasal mucosal atomizer device, or a MAD device, an indication for an intranasal mucosal atomizer device is the intranasal route can eliminate the risk of needle sticks while delivering effective medication levels to a combative patient. The rich vasculature of the nasal cavity provides a direct route into the bloodstream for medications that easily cross the mucous membrane. Due to this direct absorption into the bloodstream, rate and the extent of absorption are relatively comparable to IV administration. EMS personnel may utilize the MAD area as an alternative drug delivery adjunct for patients without IV or IO access who require the urgent administration of naloxone or Narcan and or midazolam or Versed. A nasal drug administration is quick and easy with no special sterile techniques required. The contraindications are epistaxis, nasal trauma, a suspected fractured nose, and a severe nasal congestion discharge. I'm not going to describe how to draw it up. Basically, just hook it up. It creates a spray. It works very well. But some notes. Nasal administration does not always work for every patient. Nasal administration is less likely to be effective if the patient has been abusing inhaled vasoconstrictors such as cocaine. The ideal volume for intranasal administration is 0.2 to 0.3 mL, and the maximum recommended volume per nostril is 1 mL. If the dose is greater than 0.5 mL, apply it in 2 separate doses, allowing 5 to 10 minutes apart from each dose. The spacing allows for the former dose to absorb. The mucosal atomizer device has a dead space of 0.1 ml, so particularly for doses less than 0.9 ml, be sure to take the dead space into account, adding 0.1 ml to the final volume, i.e. volume of the dose plus 0.1 ml. Ideally, the patient should be in a supine or recumbent position. If the patient is sitting, then compress the nostrils after administration. For IO access, or intraosseous easy IO access and infusion, the indications for this are: there are 3 sizes of the easy IO needles used by Annaville Fire Department. There's either the 45mm, the 25mm, and the 15mm. IV access on an emergent life-threatening patient when peripheral IV lines are unsuccessful after 2 IV attempts or 90 seconds. The patient should have evidence of hemodynamic instability, such as hypotension, poor perfusion, or respiratory arrest. An IO may be placed prior to a peripheral IV attempts in the setting of a cardiac arrest. However, it is still preferable to have an IV if it can be easily obtained. Throughout the protocols, all medications specified as intravenous may also be administered via IO or intraosseous route at the same dose as indicated by the IV route. The easy IO can be placed in either the proximal humerus for adults or the proximal tibia, depending on the paramedic's preference. The contraindications, however, are if a patient is awake, alert, and hemodynamically stable, if they have a patent peripheral line, if they have a suspected fracture of the bone selected for the IO infusion, and cutaneous infection or burn overlying the insertion sites. I'm not going to tell you how to do this. You should just know how to do this. You can look it up. Oh my gosh, there's a lot. Yeah, skip. This is something to YouTube. Note, the humeral head site can also be used in adults only. Any medications that can be administered via IV can be administered via the IO route, same dose. Sodium bicarbonate may be diluted 1:1 in normal saline prior to being administered. Medications should be administered using a syringe or pressure bag. A gravity flow will not be enough. Only use dedicated easy IO needles. Never use an angiocath to place an IO line. Only 1 IO attempt per tibia or humerus should be attempted in the pre-hospital setting. Always flush the IO line after each medication has been administered. Make sure the IO line is treated just like an IV line in regard to avoiding any air in the line during disconnection. For intravenous, IV access and infusion. To introduce this, all IV fluids will use normal saline. When establishing an IV access, the IV fluid should be based on the paramedic's judgment of the current patient needs. A saline lock, or IV at 60 mL per hour to keep the vein open, can be used in patients who do not need IV fluids, but rather a site for possible medication administration, such as for a seizure patient or adenosine for SVT, etc. A saline lock may also be established as a second IV site when it may be needed. Angiocaths should always be of an appropriate size or gauge for the patient's condition and size. IV tubing and drip rate should be selected according to the patient's needs. Medications drips should generally be set up by using the mini drip set. All hypotensive patients, trauma patients, and cardiac patients, and patients displaying decreased perfusion should have the macro drip set at 10 drops per ml volume tubing used. Patients who are expected to require a large amount of IV fluids and or may require blood at the hospital should receive IV fluids through the blood or wide tubing if it is available. In post-mastectomy patients, avoid intravenous access in the arm on the affected side. Upper extremity sites are preferably to lower extremity sites. Lower extremity sites are strongly discouraged in patients with vascular disease or diabetes mellitus. External jugular vein cannulation is indicated in critically ill patients or greater than 8 years old who require IV access for IV fluid or medication administration, and an extremity IV cannot be obtained. Err on the side of using larger needles and macro tubing in any patient that has the possibility for deterioration en route, such as an acute MI. For the procedure, I'm not going to tell you how to set up an IV. You need to look it up on your own. For the use of implanted vascular access devices. If a patient is encountered that has an implanted vascular access device, only use such device in an emergency situation in which there is no peripheral line that can be accessed. Strict adherence to aseptic technique must be maintained at all times. Cleanse the injection port with alcohol prep pads before using. An implanted vascular access site are indwelling catheter devices placed into one of the central lines to provide vascular access for patients requiring long-term IV therapy such as antibiotics, chemotherapy, or hemodialysis. Groshong, Hickman, and Broviac catheters are inserted into the superior vena cava via the subclavian vein, usually under the clavicle. Hemodialysis catheters will have a blue port, and a red port are used as temporary dialysis catheters. These can be accessed only in an emergency, a life-threatening situation. When using a hemodialysis catheter, remove at least 3 to 5 mL of catheter fluid, the heparin solution, from either port. However, by convention, it is always better to use the blue port. Then, flush the port with 10 mL of normal saline prior to attaching the IV tubing and infusing fluids or medications. Peripherally inserted central catheters, or PICC lines, are inserted into the superior vena cava via the antecubital vein. Porta A cath is a permanent catheter that is placed under the skin below the clavicle. It is used for chemotherapy and permanent IV access, including sickle cell anemia patients. Due to the risk of penetrating the subcutaneous Port A catheter tubing, they should not be accessed in the pre-hospital setting. No under-the-skin access site should be used in the pre-hospital setting, as it takes a specialized, non-coring Hubbard needle to avoid permanent damage to these IV access sites. Note: do not establish an IV in an injured extremity, in an insulin-dependent diabetic foot, or into the dialysis shunt, a surgically created arteriovenous fistula, unless absolutely necessary in an immediate life-threatening injury or situation. An external jugular IV may be placed without contacting medical control. The patient's head must be maintained in midline neutral position if any possibility of spinal trauma exists. No more than 3 IV attempts should be made in the field. Do not leave angiocath needles lying on the stretcher. Always dispose of needles properly in a sharps container. Always expel air from the IV tubing or syringe prior to administration of IV fluids or medications. This is of the utmost importance when using external jugular or an implanted vascular access device. The introduction of air into venous systems can cause an air embolism that can be fatal if large enough. For Annaville Fire Department EMT Basics, you can use a IV, but you need to pass a yearly IV class and have their skills credentialed by the Annaville EMS Medical Director. Ketamine protocol. So ketamine is an analgesic at low doses. It's a sub-dissociative and an anesthetic at high doses or a dissociative. It will be used only in low doses at 0.3 milligrams per kilograms in these EMS protocols. Higher doses, 2 to 4 milligrams per kilograms, are used in a hospital setting. The benefit of ketamine is that it provides analgesia while preserving the airway patency, no respiratory depression, and hemodynamic stability, no hypotension. Ketamine produces amnesia, sedation, as well as its analgesic effect. Ketamine can be added to opioids for synergistic pain control or used directly by itself for patients that are hypotensive and require pain control. Ketamine stimulates catecholamine release and may improve cardiac contractility. Ketamine binds to mu and kappa opioid receptors. The indications for ketamine is only to be administered by paramedics. Consider ketamine use in patients that have severe pain. Ketamine can be used in aid in airway management control with or without intubation. Pain management to be used as an adjunct with opioid administration. Ketamine may be used as a first-line analgesic when the patient presentation is appropriate for its use alone, e.g., hypotension and a patient is a chronic opioid user. Ketamine may be considered first-line for patients with severe burns or in patients with suspected multiple fractures. The contraindications: patients with a severe head trauma or a GCS less than or equal to 12. Patients with severe hypertension, paramedic discretion. Allergies or sensitivity to ketamine. And a penetrating eye trauma. Ketamine can increase intraocular pressure. A side effect: you can have emergent reactions or nightmares when waking up from ketamine. You can have hallucinations, hypertension, increased cardiac output, tachycardia, increased oral secretions, nausea and vomiting, and involuntary myoclonus. It may mimic seizure activity. Procedures, just no, blah, blah, blah. But do know that the ketamine pre-hospital dose for analgesia for all routes of administration is 0.3 milligrams per kilograms in both adults and pediatric patients. It may be repeated one time after 10 to 15 minutes. And the onset of action is 30 seconds when administered IV or IO and 3 to 4 minutes when administered intramuscularly or intranasally. The duration of the action is 10 minutes IV or IO or 20 minutes IM or IN. Note, ketamine will not be used for excited delirium patients in these protocols. Use benzodiazepines instead. Ketamine can cause excessive salivary production, which can be managed with suction. Ketamine is a pregnancy category C medication. Ketamine can cause nystagmus and may cause patient to have an eyes wide open, glazed expression while drooling. Use ketamine with extreme caution in significantly intoxicated patients. Do not use them for a patient who has a GCS less than or equal to 12. Ketamine doesn't have a reversal agent. The effects commonly seen with ketamine can be managed supportively until the drug is eliminated from the body. Laryngospasm is very rare, but a serious complication that can occur with ketamine administration. It is treated in the pre-hospital environment by providing respiratory support using a BVM. Medication administration. Nope. IM nebulizer. Fellas, we should know this. IV, oral, P means PO. Ooh, this is a good one though. Rectal or PR medications. It includes diazepam 0.5 milligram per kilogram PR or rectally in a child. For treatment of status seizures in pediatric patients where IV access is unobtainable, midazolam IM or a mucosal atomizer device should be used in adults. The IV site is preferred because rectal absorption, while rapid, is unpredictable. The procedure is to instill using a 14 gauge or 16 gauge flexible angiocath or a 10 FR pediatric suction catheter. Never administer into the rectum using a needle. Administer the diazepam 4 centimeters into the rectum. It should advance with little or no resistance. The diazepam may need to be premixed with normal saline if only a small volume of the medication is being administered. Hold the buttocks together for 2 minutes to prevent any leakage of the diazepam. So something that we rarely use. But skip. You should know how to use this sublingually. You use it for nitroglycerin, blah, 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 blah. For off-duty patient care, it is realized that the EMS personnel might encounter a patient care situation while off-duty, where their assistance may be needed. The appendix will address these situations where off-duty personnel may assist in EMS care, e.g., stopping to render aid if you should happen upon an accident or assisting a neighbor during an emergency while off-duty. This appendix does not apply to personnel that are paid or volunteer with the local fire department or EMS agency and are responding to an EMS call as a representative of that paid or volunteer fire department or EMS agency. It also does not cover personnel who are intentionally responding to a scene in another area from which they are deployed by monitoring dispatch via a scanner or other means. This off-duty patient care guideline will only cover the local South Texas area within 100 miles of Corpus Christi city limits, and assume that off-duty personnel may perform their patient care just as if an on-duty, provided that the patient care adheres directly to the protocols and standing orders found in this manual. This will include performing a patient care and treatments at their local current state level of EMS certification recognized by the EMS medical director. Remember that performing any ALS intervention, including IV fluids, invasive air management, medication administration, etc., while off-duty may necessitate you accompanying the patient to the hospital and the ambulance depending on the local area and capabilities of the ambulance. No ALS skills will be performed in an area where a BLS ambulance may be transporting to avoid any possible issues with subsequent patient care or abandonment. If there is any concern about the capabilities of the EMS agency you are assisting, it is strongly recommended that the EMS personnel only perform non-invasive BLS skills, i.e., no medications except oxygen. It is also very important for you to realize that while off-duty, you are on scene as an assistant to the crew on duty and you are there to help them. Furthermore, if off-duty in another geographic area where you are normally employed, remember that you are there to assist to help the EMS crew in the jurisdiction in which you have stopped. The local crew should maintain incident command of the scene while you are just visiting. Note, due to the wide variation of EMS levels of care and laws outside of Texas, it is strongly recommended that while out of state, only avail yourself as a Good Samaritan type role. This protocol does not apply to individuals working or volunteering as an EMT or paramedic in a situation such as a sporting event, a camp medic, a fire watch, scouting, church event, etc. Pain management. Pain is a common reason that patients seek medical attention and call EMS. Indications for considering of analgesia medication. Isolated extremity trauma, such as fractures or dislocations without head, chest, or abdominal trauma. Patient has to be awake and alert and oriented ×4 to person, place, time, and event. An exception to this is if morphine or fentanyl is being used to facilitate an endotracheal intubation and control the airway. They have significant burns. If they are a sickle cell anemia patient with a typical pain crisis for that patient. Suspected renal colic or flank pain radiating to the groin, the patient is unable to lay still, blood in the urine not associated with the abdominal pain. Suspected cardiac chest pain, including CHF or congestive heart failure, after 3 sublingual sprays of nitroglycerin without relief. The contraindications for analgesia is hypotension, which is a blood pressure less than 100 for the top number, opioid allergies, and an altered mental status, including head trauma or intoxication with alcohol or drugs. Note: assess the patient's level of pain using the pain assessment scale from 0 to 10. Morphine sulfate, fentanyl, or ketamine are to be used in the pre-hospital setting with good paramedic judgment. If any doubt exists about using it on a patient, contact medical control for guidance. Be aware that many physicians will be reluctant to order pain medications in the pre-hospital setting. Morphine and fentanyl are not to be administered to any patient suspected of abusing narcotics. Patients receiving morphine sulfate or fentanyl must be on the cardiac monitor, have a pulse ox, and have close blood pressure monitoring done between. Ideally, they should have an IV established to allow IV fluids if any hypotension occurs following the morphine administration. Sickle cell anemia patients need to have an IV fluid and oxygen in addition to the analgesics. Morphine sulfate, fentanyl, diazepam, midazolam, and ketamine are expected to be double locked in all storage areas and should only be kept in the back of the ambulance. If a patient experiences profound respiratory depression or hypotension after morphine or fentanyl, naloxone or Narcan may be administered. Diazepam or Valium and midazolam Versed are not analgesics. They are sedatives and they should not be used independently for pain control. Patient refusal of treatment or no transport. To introduce this topic, occasionally alert and oriented patients may refuse the proposed treatment and or transport recommended by the EMS provider regardless of the medical condition. However, this decision needs to be an informed one. It is encouraged that all patients who may have a significant possible injury or illness be transported to the hospital. However, individuals with capacity may refuse services and treatments. Patients with capacity must demonstrate each of the following. They must be 18 years old or greater unless the parent or guardian is present or a patient is emancipated minor, either married or court-ordered. They have to be oriented to person, place, time, and event, or ANO ×4. They may not be actively homicidal, cannot be trying to hurt themselves, or display irrational thinking. No evidence of impaired judgment manifested as significant intoxication, incoordination, slurred speech, or disorientation. A patient must understand and can express the understanding of his or her illness or injury and potential for adverse outcomes, including death, of not treating his or her illness or injury. A patient must understand the consequences of their decision. All patients less than 18 years old must have a legal guardian contacted as soon as possible unless they're emancipated. And an emancipated minor is one who is or has been married or has his or her classification of a minor removed for general purposes in accordance with Texas Family Code. If the patient has an emergent illness or injury, implied consent is invoked and the patient should be transported to the hospital, with the parents being contacted as soon as possible. Implied consent is whatever a reasonable individual who would consent to under the same circumstances. The parent or legal guardian must sign the refusal of transport if possible, or a verbal refusal over the phone with a witness. A law enforcement needed if possible, and may suffice in certain circumstances. Contact medical control for guidance as needed. Establish and document competency to refusal of care on the EMS patient care report. Enlist the help of family members and friends in changing the patient's mind if necessary. Look for and negotiate alternatives if needed. So, the procedure is, when a patient refuses care, the following procedure will be followed. This must be documented in the patient EMS care report. The patient will be thoroughly evaluated with pertinent history and physical findings communicated to the patient. Treatment, interventions, and transport will be offered. The risk of refusing care must be discussed and documented in the patient care report. Risks shall include permanent disability and death. The patient must understand these risks of not seeking medical attention. Ideally, the patient should recite back the nature of his or her illness and medical condition, the risk and benefits of the proposed care, and the risk of refusing the proposed care. All patient questions should be answered. Reasonable scene treatment should be offered. A witness signature must be obtained on the patient care report. This can be a law enforcement or your partner if no other family or competent friends are available. Patient will fall into one of the 4 following situations in the table below. The patient must be assured that at any time in the future the ambulance will respond for any other illness or injury that may occur. This may call EMS back for assistance in the future as needed. In the patient care report narrative, thoroughly describe the patient's encounter, vital signs, and medical advice given. You need to check these things. You can pause and read it if you would like. But note, involve law enforcement on all patients without capacity who are refusing to go. If the patient has an injury or illness with no potential for loss of limb or life, on the paramedic's judgment, contact medical control for guidance as needed. The physician will either order a transport to the hospital or a refusal based on their assessment of the situation. If the patient without capacity has an injury or illness with potential loss of limb or potential life injury, based on the paramedic's judgment, contact medical control and bring the patient to the hospital using law enforcement as needed. It is recognized that various law enforcement agencies and individual officers will have different levels of support for EMS regarding patient care refusals. Always involve medical control as needed. If a patient with capacity has unstable or severely altered vital signs and is refusing transport, contact medical control for guidance. Often, any patient with significant abnormal vital signs cannot be considered to have the capacity to refuse care. The patient's signature should be obtained in legible script. Unsteadiness may imply that the patient is not medically capable or mentally able to think and act rationally. All efforts should be made to have the patient to sign the refusal form. If they continue to refuse to sign the refusal form, properly document the patient and describe what happened. Also try to get a third-party witness. A witness should be non-biased individuals who actually witness the patient's signature. If available, law enforcement can be selected to sign as a witness. Situations involving multiple refusals, i.e. a school bus collision, may have all refusals listed on a common EMS patient care report. This should list the names of the people who are refusing and the treatment and should be signed by a person taking responsibility for all these patients refusing, such as a school administrator, the responsible driver of the vehicle, a bus driver, etc. An EMS personnel should at no time mention the cost of transport, status of the system, the unit availability, or any other non-clinical subjects in an attempt to influence a patient's decision to accept or decline a treatment and or transport. A witness must sign the patient refusal. If a witness is not available, please document this in your patient care report. Patient restraint, transporting against a patient's will or combative patients. To introduce this topic, occasionally, patients may be encountered that refuse transport to a medical facility, but may be suffering from an illness or injury that impairs their ability to make an informed decision. If the patient does not have capacity, as outlined below, and the pre-hospital provider feels that the patient needs emergency medical treatment or evaluation, the patient should be transported to the emergency department for further evaluation and treatment. See page 166 for further information. If the patient is displaying behavior which is an immediate threat to the health and safety of themselves and or the pre-hospital providers, the patient may need to be safely and humanely restrained. Inform the patient of the reason for the restraint. Any patient that is agitated needs to be closely examined for correctable causes of agitation, e.g. hypoxia or hypoglycemia. Physical and or chemical restraints should be used as a last resort technique. Attempts should be made to de-escalate verbally aggressive behavior with a calm, reassuring approach and manner. Use only the minimum amount of force necessary to restrain the patient and make sure that there are enough personnel on scene to safely place the patient in restraints. The patient should be searched for weapons prior to transport. Realize that every patient with a capacity has a legal and moral right to refuse transport, even if that treatment or transport refusal results in potential harm to the patient. Hostile, angry, or unwilling patients who have the capacity may refuse service. The pre-hospital provider must make sure that if a patient refuses, he or she has the capacity to do so and is able to make an informed decision. See page 166 for more info. Only restrain with soft restraints. Commercially available wrist and leg restraints, cravats, cling, curlex, sheets, and etc. If handcuffs are used by law enforcement, the officer should either accompany the patient in the ambulance or follow the ambulance in a patrol car to the hospital. Restrain patients in a manner that does not impair circulation, cause choking or aspiration. See excited delirium on page 45. For scene safety, never attempt to restrain a patient without proper law enforcement assistance. Do not endanger yourself or the crew. Assess patients if they're able to determine if the patient has capacity, if their age is greater than 18 years or older unless a patient, parent, or guardian is present, or if the patient is an emancipated minor that's either married or court-ordered. If they're ANO times 4, if they're not actively homicidal, if they don't want to hurt themselves, or if they're displaying irrational thinking, no evidence of impaired judgment manifested as the odor of alcohol, incoordination, slurred speech, drug use, or disorientation, a patient understands his or her illness or injury, and the potential for adverse outcomes, including death, of not treating his or her illness or injury. If EMS providers feel that the patient is not capable of making an informed decision and has a potential for serious illness or injury, the patient should be strongly advised to seek medical care. Always rule out the causes for combative behaviors such as hypoxia, hypoglycemia, hypotension, head injury, etc. A patient who has capacity, as outlined above, may refuse medical treatment and transport. Never restrain a patient in the prone, face down, or hog-tied position. Plastic restraint devices such as a nasal cannula, duct tape, etc. are not to be used. Contact medical control for assistance if any question arises regarding the care and transport of a combative patient. Documentation of the patient care report should include the reason for the use of the restraints, the type of restraints, and the time that the restraints were placed. For Pediatric Patient Transport Guidelines, the purpose is to provide a safe method of transporting pediatric patients within an ambulance, and it's to protect the EMS systems and personnel from potential harm and liability associated with the transportation of pediatric patients. The procedure is to tightly secure all monitoring devices and other equipment. It's to ensure that all pediatric patients less than 40 pounds are restrained within an appropriate, approved child restraint device secured as per the manufacturer's instructions. You want to ensure that all parents, caregivers, or other passengers are properly restrained during transport. Do not allow the parents or caregivers to hold the patient during transport. For patients with medical conditions that may be aggravated by stress, e.g. croup, partial airway obstruction, make every attempt to optimize safety when comforting the child and transporting. It is best not to transport any pediatric patient meeting trauma code criteria in a child safety seat that was involved in the collision that produced the child's injury. If you guys would like to pause right here, this is a table that goes over the pediatric patient weight, heart rate, and systolic blood pressure by age. You can see some of the examples here. You can pause it if you would like. Just note that you want to make sure that the blood pressure obtained are within the correct size blood pressure cuff. Too large of a cuff will give a falsely low blood pressure reading, while too small of a cuff will give a falsely elevated blood pressure reading. Medications dosing in pediatric patients should be based on the patient's weight and not on their age. The median systolic blood pressure for a child from age 1 to 16 is estimated with the formula median systolic blood pressure equals 90 units plus parentheses 2 times their age in years parentheses. The lower limit is going to be 70 plus parentheses 2 times age in years parentheses. For a pediatric endotracheal tube size, you want to do age divided by 4 plus 4. If you have a physician intervener or an on-scene physician, to introduce this, the EMS medical director and or the online medical control physician are ordinarily responsible for patient care in the field. Occasionally, a physician will be present on the scene of a call, which may cause confusion, uneasiness, and mediological or medico-legal considerations. 2 scenarios are possible whenever this happens. The physician who knows the patient has established a formal doctoral-patient relationship, or the physician does not know the patient. Both scenarios present with difficult different physician responsibilities. Cooperation and communication are essential. Pre-hospital providers should recognize and acknowledge the expertise of any other medical professional, such as an RN, an LVN, a nurse practitioner, a respiratory therapist, physician assistant, etc., and use them for the best outcome of your patient. The physician with an established doctor-patient relationship. EMS personnel will assess and manage the patient upon arrival at the scene regardless of the on-scene physician direction. This applies to a physician's private office or clinic. Should the on-scene physician wish to assume control of a patient management, he or she may be able to do so. If the paramedic is uncomfortable with any specified treatment or management of the following, these must be satisfied. Communication established between the medical control physician and the on-scene physician. The on-scene physician agrees to accompany the patient in the ambulance to the hospital. In the event the intervener on-scene physician agrees to assume control and the two above criteria are satisfied, then the following medico-legal details must be adhered to. Orders given by the on-scene physician must be carried out by the EMS crew provider, provided that they are part of the provider's level of training. Orders that are not must be done by the intervener physician. All orders given by the on-scene physician must be signed by the physician on the EMS patient care reports. If the paramedic feels uncomfortable about any aspect of the patient care in the field, he or she must contact medical control and communicate those concerns. The online medical control physician has the authority to supersede any or all of the orders given by the intervener physician at any time during the pre-hospital phase. The physician without an established doctor-patient relationship. For an EMS personnel, they will assess and manage the patient upon arrival at the scene regardless of the on-scene physician direction. If the physician on scene agrees to assume care of further patient management, all the following must be satisfied and told to the intervener physician. The physician must show proof of current Texas medical license, a wallet card with the name, medical license number. If possible, see the photo at the right. If any doubts of their identity exist, the physician must provide proof of further identity if he or she wishes to assist with patient care. A physician must accompany the patient to the hospital in the ambulance. An intervener physician who elects not to accompany the patient to the hospital will immediately and automatically relinquish control to the online medical control physician. The physician must carry out all orders that are not part of the pre-hospital provider's training. The physician must sign all orders given on the EMS patient care report. The physician must assume complete medico-legal responsibility for all patient care activities until such care and time is formally transferred to another physician at the receiving hospital. The medical control physician may supersede the on-scene physician at any time during the pre-hospital phase. For special situations, in the event of a mass casualty incident or an MCI, an on-scene physician may be best utilized at the scene and not accompany a patient to the hospital. If the on-scene physician wishes to terminate resuscitation measures, he or she may do so, provided that this action is communicated to and concurred by online medical control. Orders communicated for patients undergoing intrafacility transport should be followed as long as those orders are within the paramedic's level of training. If possible, those orders should be signed by the transferring physician. For a non-physician medical personnel on the scene, if a bystander at an emergency scene identifies himself or herself as a healthcare provider other than that as a physician, the EMS provider should inform the individual that he or she may assist the emergency team and or offer suggestions, but may not assume medical management for this patient. These individuals should not be with direct patient care. For pleural decompression or needle thoracostomy is indicated for the treatment of a tension pneumothorax manifested by all three of the following: hypotension with a systolic blood pressure less than 100 units, decreased breath sounds, shortness of breath, or increased resistance to bagging. In addition to these three things, the patient may also have JVD or jugular vein distension, tracheal deviation, hyperresonance to percussion, and cyanosis. A pleural decompression or needle thoracostomy cannot be done unless the patient has all three of the hallmarks above, with the exception of the traumatic arrest with PEA, which may have bilateral pleural decompressions performed without all three checked above. In an intubated patient, always check the depth of the ETT tube before performing pleural decompressions. The ETT may be too deep, usually a right mainstream bronchus intubation, that will cause decreased breath sounds on the left side. A pleural decompression may be done prior to contacting medical control given the urgent nature of its condition. For a paramedic only, apply oxygen via a non-rebreather mask or a BVM, or intubate if needed. Have the patient on the pulse oximeter. Expose the chest site. Cleanse the insertion site, the fifth intercostal space, anterior axillary line with an alcohol prep pad. Attach a 12 gauge to 14 gauge angiocath to a 10 ml syringe. Saline may be placed in the syringe to help with placement, since air bubbling will occur. Pass the angiocath through the end of an exam glove to establish a one-way flutter valve. Alternatively, a commercial type flutter valve can be used. Identify the fifth intercostal space between the fifth and the sixth rib. Insert the angiocath directly over the top of the sixth rib in the anterior axillary line perpendicular to the skin. See the illustration in the next page. The syringe should be aspirated while advancing the angiocath needle. Note any rushing of air. Once the pleural space is entered, a loss of resistance, and air aspirates into the syringe, advance the catheter into the pleural space until the hub is flush with the skin. Remove the needle, leaving the angiocath in place. Secure the catheter in place using tape. Reassess vital signs and breath sounds. If needed, the above procedure can be repeated. Note, for pleural decompression, it is not indicated for a suspected simple pneumothorax or a hemothorax. It is only indicated for a tension pneumothorax manifested by hypotension, decreased breath sounds, hyperresonance, and shortness of breath, or increased resistance to bagging. Tracheal deviation away from the affected site is a rare and late finding. Therefore, the possibility of a tension pneumothorax should not be ruled out in its absence. Remember that while the pleural decompression can be life-saving in a patient with a tension pneumothorax, it used in a stable patient without hypotension, decreased breath sounds, or a shortness of breath can be costly. All patients who receive pleural decompression in the field will need a subsequent chest tube placed in the emergency department, which may necessitate a hospital admission for 2 to 3 days. Always leave the plastic angiocath in place so the ED staff will know the pleural space has been entered. If at any time a pleural decompression is performed on a patient, it is imperative that the receiving ED personnel must be aware that a pleural decompression was attempted or done. This is to avoid a possible tension pneumothorax later. Always remember to remove the needle from within the angiocath once the pleural decompression has been performed. Ideally, the angiocath needle should be used 3 inches in length. This is to make sure that the angiocath are long enough to enter the pleural space in an obese patient. The second intracranial midclavicular line is a recommended insertion landmark by ATLS. However, new evidence shows that the fifth intercostal space anterior auxiliary line may be better with the advantage of a thinner chest wall and no major blood vessels near, being further away from the subclavian vessels and internal mammary artery and its medial branches. So here's an image of it. You want to aim for somewhere right around here. For pulse oximetry, continuous pulse oximetry should be utilized in all patients with an inadequate respiratory function. Pulse oximetry is an important tool for determining the oxygen saturation of the patient. However, be aware that there are several limitations where pulse oximetry is inaccurate. If there's carbon monoxide poisoning, cyanide, or methyl poisoning, these 3 conditions likely cause a falsely elevated reading, as the pulse ox measures percent of hemoglobin bound and does not discriminate if it is bound by oxygen, carbon monoxide, or other toxins. Hypovolemia with poor perfusion. The probe will have a hard time detecting capillary blood flow due to low perfusion status. Cardiac arrest, hypothermia, severe anemia, vasoconstriction, such as a norepidrip, etc., and finger polish. Now, always treat the patient and not a pulse oximetry reading. The pulse ox should be used in conjunction with an accurate patient history and physical examination. Some indications for this are a patient receiving morphine, fentanyl, ketamine, diazepam, or midazolam, an adjunct to a patient assessment while administering oxygen, patients with shortness of breath, chest pain, or an altered mental status, patients with trauma to the chest, during and after an endotracheal intubation. You assemble the equipment, you attach it on their finger, and document the level of it. It's not very complicated. The pulse oximetry is a good tool to monitor a patient's respiratory status, but should be used in great caution in diagnosing a respiratory problem. Remember, the pulse ox is measuring the percent hemoglobin bound with oxygen, but gives no other information on their ventilation. A good pulse oximetry reading should never be used as the sole determinant to withhold oxygen from a patient in respiratory distress, or when it is a standard of care to apply oxygen, such as a cardiac chest pain call. For radio communication or online medical control, A radio report must be given to the emergency department on all patients being transported to the hospital. The patient care report should be given to the hospital the patient is being transported to, i.e. the receiving hospital. If the receiving hospital cannot be contacted, Christus Spawn Shoreline will be serving as a medical control hospital for the area. Physicians' online medical control situations required in the field protocol manual will be in the bold type. Always contact medical control when any question arises regarding any aspect of patient care. Medical control should be contacted and must be for pronouncement in the field when CPR has been started or difficult situations arise, such as a patient refusing care, etc., or in other instances when indicated in this protocol manual. In situations where either 3 or more critical care patients or 5 total patients are being transported to the same hospital concurrently from the same incident, it is imperative that the receiving emergency department be informed of the situation as soon as possible, preferably while still on scene. This is to ensure that the appropriate emergency department and hospital resources can be assembled to optimally care for these patients. When medical control is not available due to natural disasters or malfunction, these patients in the field protocols and standing orders must be followed exactly. For the procedure for patient care report, the patient report should be concise, accurate, and adhere to the guidelines below. The radio report on a non-emergent patient should be brief. Only report the patient's past medical history, medications, and allergies which are pertinent to the patient's chief complaint. Remember that hundreds of people are using the scanners, including the media, and will be listening to your patient report. Do not use slang terminology. Be very professional on the radio. Never say the patient's full name or the words drunk, R-word, or sexual assault. Ectopics is not a word by itself in regard to cardiac dysrhythmias. Instead, say ectopic beats. Do not use radio 10 codes during radio communications except for 10-4 for OK. Speak slowly with good pronunciations of the words. The patient's race or national origin should not be given over the radio. Give the patient's radio report as soon as possible once en route to the hospital to allow for adequate emergency department preparation, such as room cleaning, equipment, personnel, etc. Make sure that the completed EMS patient care report is left at the emergency department prior to departing from the receiving hospital. Only under unusual circumstances should the ambulance depart without leaving a copy of the EMS patient care report. Here's an example of a report if you want to pause it and take a look. This is a really good example, but I'm going to move forward. For ResQCPR system, the purpose of the ResQCPR system is this document provides suggested recommendations for the use of this system, which includes the ResQ POD-ITD-16 and the ResQ pump ACD-CPR device. The ResQ POD-ITD-16 is an impedance threshold device, an ITD, that regulates the airflow into the lungs during CPR to enhance negative pressure, i.e. a vacuum in the chest, allowing more blood to be pulled back to the heart and lowering intracranial pressure. The ResQ pump, an ACD-CPR device, is used to perform the active chest compressions, decompressions through CPR, which is intended to promote complete and active chest wall recoil to further enhance the vacuum. Used together, these devices increase blood flow to the brain and vital organs and may improve the likelihood of survival. I'm not going to describe this, but just know the contraindications are that for pediatric patients less than 18 years old and traumatic cardiac arrest, you can look up this equipment. It's a very cool piece of equipment that we have. It's 2 pieces, and I have seen good success with this. Note, improper use of the ResQCPR system could cause serious injury to the patient and ineffective chest compressions or decompressions. The ResQCPR system should only be used by personnel who have been trained to use it. Improper positioning of the ResQ pump suction cup may result in possible injury to the ribcage and or internal organs, and may result in suboptimal circulation during the ACD-CPR. Do not use the ResQ pump if the patient's chest is not large enough for the ResQ pump suction cup to provide adequate compressions or decompressions during use. Moisture, gels, or other lubricating materials on the patient's chest should be removed before applying the ResQ pump. Failure to do so may result in sliding of the suction cup of the chest and ineffective chest compressions or decompressions, and possible injury to the ribs or internal organs. This device should not be used in patients who have recently had a sternotomy. For these device in patients with a recent sternotomy, within the past 6 months has not been evaluated, but the potential chance for a serious injury is there. If you achieve ROSC during the efforts with this device, should be immediately removed from the airway circuit and the use of the pump should be discontinued. Failure to do so may cause shortness of breath, difficulty breathing, and potential pulmonary edema if the patient begins to breathe spontaneously. Okay, the appropriate amount of force. Good luck trying to measure that. Regarding spinal motion restriction or immobilization clearance in the field, the paramedic clearing of a cervical spine in the field. Spinal motion restriction of the patient may be omitted if all of the following conditions exist and are documented clearly on the patient care report. No exceptions. Strict adherence to these guidelines must be maintained. A patient must be greater than or equal to 8 years old. Children less than 8 years old need to be spinal motion restricted as they cannot consistently verbalize neck pain. They need to be ANO times 4 with good short-term memory. They must have a normal neurological exam. Normal neurological exam. They must have motor and sensation in all 4 extremities. No focal neurological deficits, including tingling, reduced strength, or numbness in any extremity. No evidence of drug or alcohol abuse. No evidence or reliable history of loss of consciousness. No complaints of neck or back pain. No penetrating injuries near midline spine area. No distracting injuries defined as any significant painful injuries. For example, long bone, such as the femur, the humerus, or the tibia fractures, abdominal pain, chest pain, and pelvic fractures, etc. No strong evidence of potential spinal injury in the mechanism of injury, such as a high speed, severe damage to the motor vehicle crash, ejection from the vehicle, and falls from great height. Note, the decision to not implement spinal motion restriction in a patient is the responsibility of the lead paramedic on the call. The clearing of cervical spine must not be abused by pre-hospital providers. It will be assumed that the patient can speak English or that a reliable translator is available on scene to assist with the questioning. It is not permissible to clear the C-spine in a patient who cannot communicate effectively with the pre-hospital provider, such as a language barrier or deafness, etc. Always consider spinal motion restriction in any patient with arthritis, cancer, or other underlying spinal disease or bone disease. In the very old, a normal exam may not be significant or sufficient to rule out spinal injury. Never test C-spine range of motion if the patient has a midline spinal tenderness. For synchronized cardioversion, defibrillation, or the automatic internal cardiac defibrillator, the AICD, to introduce this, for synchronized cardioversion, the monitor searches for the peak of the QRS complex and delivers a shock a few milliseconds after the highest part of the R wave. This avoids shock delivery during the vulnerable period of ventricle repolarization, the T wave, which can induce ventricular fibrillation. Defibrillation is whenever the monitor will deliver a shock without regard for the rhythm. An AICD is a permanent defibrillator implanted into the patient, usually in the abdomen, which senses ventricular fibrillation and VTAC and fires automatically. For the procedure for synchronized cardioversion, you apply the pads on correctly, press the synchronized button. If you need to, you can sedate a patient using 1 to 5 milligrams via IV, IO, IM, or mucosal atomizer device 1 minute beforehand, as long as it's appropriate. Select the appropriate energy level. For a patient, we're going to do, for SVT, atrial fibrillation, or atrial flutter, you do 120 joules or 1 joule per kilogram. Charge it and go ahead and depress it after no one's making contact. And then you repeat as such, If the rhythm deteriorates into VFib or pulseless VTAC, switch off the synchronized mode and defibrillate immediately. Refer to the VFib or unstable VTAC protocol on page 80. For the procedure for defibrillation, you do 200 joules or 2 joules per kilogram, just for like the regular cardiac monitor, and then you reassess. Use your correct protocols as needed. For an AICD, if a patient's AICD is discharging, the main dilemma is to determine whether it is delivering shocks working properly or if it's not. Place the patient on a cardiac monitor and note when the AICD is firing. If the unconscious patient receives shocks from the AICD, but VFib or pulseless VTAC persists, then deliver external defibrillation anyway with the normal amounts of defib energy. Avoid placement of the self-adhesive electric pads over the AICD. Defibrillate as you normally would using if you had VFib or VTAC on page 80. If a conscious patient is receiving the appropriate shocks from the AICD, no external synchronized cardioversion is necessary as long as they remain conscious. Administer lidocaine, 1.5 milligram per kilogram IV is needed. The lidocaine may be repeated at half its original dose, up to 3 milligrams per kilogram IV maximum. If the AICD appears to be shocking inappropriately, usually during sinus tach or SVT, begin rapid transport to the hospital. In the emergency department, a donut magnet can be used to inactivate the AICD. Note: atrial fibrillation rarely causes hypotension by itself. Always look for other causes. Cardioverting AFib can be risky due to the potential chance for dislodging thrombi in the heart. Use very careful judgment when deciding whether to cardiovert AFib. Medical control must be contacted prior to cardioverting AFib. Do not cardio a potential digoxin toxic patient. Rapid defib is the most important intervention for patients in VFib or pulseless VTAC. If the patient has a permanent pacemaker, place the electrode self-adhesive pad as far away as possible from the pacemaker. Any medication patches, such as nitroglycerin, clonidine, etc., should be removed prior to synchronized cardioversion or defibrillation. Tranexamic acid or TXA protocol. To introduce this, TXA is an antifibrolytic medication that prevents the breakdown of clots formed in a bleeding patient. TXA forms a reversible complex that displaces plasminogen from fibrin, resulting in inhibition of fibrinolysis. It also inhibits the proteolytic activity of plasmin. TXA has been shown to reduce overall mortality and death due to bleeding among severely injured trauma patients, especially in the first 3 hours following injury. The purpose of TXA is to reduce blood loss in trauma patients with severe hemorrhaging. For indications, TXA should be administered to hemodynamically unstable trauma patients who are felt to have non-compressible or ongoing hemorrhaging, such as a systolic blood pressure less than 100 units that is not amendable to tourniquet use. Major trauma with suspicion for pelvic and or abdominal injury, signs of hypoperfusion and altered mental status, cool extremities, delayed capillary refill, etc., blunt or penetrating trauma, patients with suspected or known specific hemorrhaging that are known or thought to be within 3 hours of their injury. For contraindications, it's known hypersensitivity to TXA, active thromboembolic disease, including DVT, disseminated intravascular coagulation or DIC, or history or risk of thrombosis. It's not indicated for patients less than 16 years old, a suspected CVA, MI, or PE. Medical control should be contacted prior to administering TXA to patients taking warfarin or Coumadin. Non-hemorrhagic and non-traumatic patients, isolated head injuries, injuries greater than 3 hours old, known pregnancy stated by a patient or obviously pregnant clinically. The procedure is TXA is supplied in vials of 1,000 milligrams by 10 mL. The standard loading dose is 1,000 milligrams via IV. Withdraw it and administer it into a 100 cc bag. Infuse it over 10 minutes. Do not inject more rapidly than 100 milligrams per minute to avoid hypotension. The 1 gram of TXA IV should never be administered faster than 10 minutes. Clearly document in the patient care report the mechanism of injury, the time of it, indications for TXA, and the time it was administered. Make sure the receiving staff at the trauma center is aware that TXA was administered in the pre-hospital setting. This notification is vitally important, and the names and nurses and the physicians told should be documented on the PCR. Note: TXA will be started by EMS as a 10-minute bolus. The 8-hour infusion will be completed later in the hospital. Don't forget the basics. In a bleeding patient, hemorrhage control and appropriate resuscitation should remain the priority. Hypotension can worsen if infused too rapidly, and TXA may also cause nausea, vomiting, and diarrhea. For the revised trauma score for adults and pediatrics, here's a scoring. If you want to take a moment to pause the video, you can see that they check the GCS scoring, the blood pressure of a patient, the respiratory rate, and score it from 0 to 12. For a pediatric trauma score, we check the patient's weight, their airway, their central nervous system, their blood pressure, any open wounds, or any possible bone injuries, and we tally that up. For the VAN acute stroke screening tool, you want to check that the patient has any arm weakness. If yes, continue the VAN assessment. If no exam arm weakness, the patient can hold both arms up to 10 seconds, then the patient is VAN negative and stop the VAN exam. If a patient has any degree of weakness, plus any one of the VAN positive criteria below, then the patient may have a large clot, a cortical symptom. These patients should be transported to an endovascular capable hospital, with the receiving hospital notified in advance of a VAN positive patient arriving. So we check for visual disturbance, aphasia, and neglect. So visual disturbance, you want to assess the visual fields by testing both sides using fingers, evaluate for blind spots using fingers to test all 4 quadrants, have the patient look left, right, and assess for double vision. For aphasia, we want to check if they can speak properly. Don't count the slurring of words or understand words. Repeat and name 2 objects, close their eyes to commands, and make them make a fist on command. For neglect, you want to check if they have a forced gaze to one side, or if they're ignoring one side when touching both sides. This is a Zoll Life Vest. I'm going to skip this part. However, if a patient is encountered wearing the Zoll Life Vest, proceed with standard evaluation and treatment measures. CPR can be performed as long as the device is not broadcasting any voice commands. If the EMS provider has external defibrillation available, a decision can be made to disable the Life Vest by removing the battery located in the monitor unit. They can then place their own monitor and defibrillator device on the patient. Be aware, the Life Vest has an appropriate alert sequence that is initiated upon recognition of a treatable shock. You need to make sure to listen to the voice prompts before making physical contact with the patient. An EMS provider can be shocked if in contact with the patient during the treatment sequence. If the Life Vest has blue stains, the device has already delivered a shock. The Life Vest therapy pads release blue gel prior to defibrillation, improving electrical conduction and reducing skin burn. After the Life Vest detects a ventricular dysrhythmia, VTAC or VFib, which is unstable VTAC, time to defibrillation will be between 25 to 60 seconds depending on the exact dysrhythmia characteristic. Avoid patient contact during defibrillation. The Life Vest will warn of impending defibrillation with a tactile vibration alarm and a 2-tone siren alert and a voice command stating, "Electrical shock possible. Do not touch the patient," or "Bystanders do not interfere." Avoid CPR with the Life Vest powered on. To ensure powered off status, remove the battery from a Life Vest monitor. Unbuckle or remove the garment as needed for access to the patient's chest. The Life Vest monitor should be discontinued from the electrode belt prior to delivering defibrillation with an AED or manual monitor defibrillator. The garment and the belt do not need to be removed. All Life Vest systems components should be transported with the patient to allow for data download and component checks at the hospital when indicated. The Zoll Left technical support can be contacted 24/7 at 1-800-543-3267. So if you want to learn more about it, just look it up yourself, but just note those things. The Community Paramedicine Outreach Program. The Community Paramedicine Program will utilize the current patient care field protocols and standing orders. Occasionally, a community paramedicine patient may require transport to a non-emergency department facility, such as a doctor's office. Ideally, this transport will be performed in one of the backup, i.e. non-frontline ambulances. While on these non-emergent patient transports, if a medical emergency arises, the patient's care field protocols and standing orders will be followed. If any special situations arise, contact online medical control immediately. This page is in regards to COVID-19 whenever it's sparking up. However, I don't really feel like it's viable anymore. It was a really good protocol in place in case we had an emergent COVID patient and maybe like they actually didn't need to go to the hospital. It was really good protocols. Very thankful for them. We will be skipping over it though. And now we're going to look at one of our newer protocols, the LifeVAC airway clearance device. So LifeVAC is a non-powered, non-invasive, portable airway clearance device developed for resuscitating a victim with an airway obstruction when current choking protocols have been followed without success. Refer to page 20. It is a simple rescue device that can be used on somebody disabled, pregnant, or of large stature. Now, I highly recommend that you look into this. It's a very cool device that we just got our hands on, and for the general public, you can also get this equipment. You can find it probably like on Amazon or something. It's a really cool device to have on hands, especially if you have like a young toddler. Ladies and gentlemen, it's done. It's done. I'll never do this again. It's done. Oh, and I'm so thankful for my amazing protocols by my amazing medical director. If he does not like that I made an audio recording of this and a video of it, I will sadly delete this, but I respect his opinion. So very special thanks to him. He is amazing. I hope this helps out anybody who's either working at Annaville Fire Department or anybody who's just interested in seeing kind of our thought process on everything. These protocols are used as like guidelines for things, something that we can fall back on, but maybe if we need to make adjustments, we have the ability to do so, and we also have an amazing medical control staff that we can contact at any time if we have any questions. Thank you guys so much for watching. It's probably going to take me like 4 or 5 days to edit all the and I probably won't edit them all, and I'm sorry. But if you did like this video, please like, comment, and subscribe. It helps me a ton. Shows me that you like this kind of content. But with that being said, we will leave it at that. Any questions, just leave a comment. Thank you so much for your time. See ya.